Hello, I am Woo-Jin Jeong from Seoul National University, Bundang Hospital. Today I would like to talk about the experience of TORS complemented by neoadjuvant chemotherapy and also neoadjuvant immunotherapy. So, induction chemotherapy in head and neck squamous cell carcinoma. Uh, I would like to first talk about induction chemotherapy. Chemoradiotherapy remains the standard of care in head and neck locally advanced cancers. The role of induction chemotherapy remains controversial largely because the two major trials in early 2010, which were the Paradigm trial and the DECIDE trial, failed to demonstrate improved overall survival. And also there were concerns about the toxicity of the DECIDE trial and a significant number of adverse events and compliance issues were. So the Paradigm and the DECIDE trials were have failed largely because they were underpowered because of poor accrual, and the HPV status was not well known at that time. So the HPV status of each of the arms are not properly um, analyzed. But if you look closely at the data, you can see that the blue one is the induction chemotherapy followed by CRT seems to have a better recurrence-free survival. And if you see the blue line here, you can see that the distant recurrence rate is much lower in the induction chemotherapy, and that reaches a statistical significance. There was a recent trial, Cortec 2007/02, which was published recently, showed a similar result, and they showed that the distant metastasis was reduced in the induction arm. So what do we know about the induction chemotherapy in 2020? We know that the taxane is important, and we should not omit taxane in the induction chemotherapy. Secondly, there may be some advantage in distant metastasis control, particularly in the high risk subset with extensive nodal involvement. This is important because many of the HPV positive cancers these days have a distant metastasis failure, more of a distant metastasis failure than the local regional um, uh, recurrence. Thirdly, induction chemotherapy still has a role in the organ preservation in larynx and hypopharynx cancers, as you can see in this most recent NCCN. And there's also a role of chemoselection and bioselection. So after one or two cycles of induction chemotherapy, you assess the response, and you can actually devise the treatment scheme for that patient according. Um, I have been mentioning the induction chemotherapy, and there's a need to actually differentiate the induction chemotherapy with the neoadjuvant chemotherapy. Because induction chemotherapy is a pre-radiation chemotherapy, whereas a neoadjuvant chemotherapy is a chemotherapy administered before surgery. And RT and surgery are completely different treatment modalities. And although you are giving a similar dose and a similar drug as a chemotherapeutic agent, the role in the RT and the role in the surgery is different for each of the chemotherapeutic agents. So what I actually want to, so there is more evidence in the induction chemotherapy, but what I want to focus more is on neoadjuvant chemotherapy, which occurs prior to surgery. And because has been a improvement in the surgical skills because of um, the robotic system. So neoadjuvant chemotherapy is important in surgery because first of all, you can establish a pathological diagnosis and also staging. And secondly, you can also have do a bioselection, and that will direct the need for adjuvant chemotherapy, adjuvant therapy. And because of that, there's a possibility of de-escalation, and with the de-escalation, there's a chance of improvement of QOL. The classical theory behind the surgery still tells you that the extent of the surgery has to be the same, and in order to routinely administer neoadjuvant chemotherapy, there still is a lack of evidence to support. But theoretically, there are a lot of advantages when you combine neoadjuvant chemotherapy with TORS, because the robotic system already has its own, and combined with neoadjuvant chemotherapy, um, your approach is minimally invasive with excellent local control. As I mentioned before, the leading cause of death in HPV-positive oropharyngeal carcinoma is the distant metastasis, and there could be some advantage in distant metastasis control by applying the neoadjuvant chemotherapy. And that should be done with the appropriate regimen, because you should be including the taxane as the evidences have shown. And by selection process is also available, and there's an opportunity for de-escalation, especially the dose of the radiotherapy, and also you can omit the radiotherapy totally, and that could eliminate the long-term sequelae of the radiation, which we have been observing after a very long follow-up. So there has been a little evidences that are coming, and I believe there will be more in the near future. And this one is from the Yonsei University, from the organizers actually, and they took the advanced oropharyngeal cancers, they did a neoadjuvant chemotherapy, and applied TORS to these patients, and they were able to obtain a negative margin in about 2/3 of their patients. They were able to omit the radiotherapy in about 13% of their patients, and they could achieve a 5-year survival rate and a disease-free survival rate of about 80%. The critics that they get for this study is that they used the TS1, which is an oral form of the 5-fluorouracil, and did not put the taxane in the study, which is a critic point. And this is not an RCT, so there's no control group to prove that your result is superior to control. There recently has been a article in Head and Neck, in which they have used the cisplatin and the docetaxel induction chemotherapy, and actually their 5-year survival rates are much higher, 96%. And as you can see in this Kaplan-Meier survival curves, the blue one is the neoadjuvant chemotherapy followed by surgery, compared to the CCRT is faring better, especially the C box, which is the disease-free survival. And they have also shown that the feeding tube dependency is much better in the neoadjuvant chemotherapy group compared with the CCRT group. In our hospital, we had an experience with this 59-year-old gentleman who had a left araepiglottic fold mass. The biopsy was a squamous cell carcinoma, which was a P16 negative. He's a current smoker with a 20-pack year smoking history. So as you approach the laryngoscope, actually the tumor seems to be not that big, but as you introduce the laryngoscope even further, you can see that there's a huge mass in the araepiglottic fold. Fortunately, it's a pedunculated mass and not that much infiltrative. And on the larynx CT, you could see that there is a supraglottic cancer with ipsilateral nodal metastasis. And his tentative stage was clinical T3 and 2. And we put him on 2 cycles of DP neoadjuvant chemotherapy. And his primary site was near CR. As you can see in this laryngoscope, you no longer can appreciate that tumor. And even if you put the laryngoscope further in, you can barely actually see the tumor. The next CT also showed the same results. We plan to do TORS, and we plan to incorporate all the primary tumor that was evident on the exams visit. So we did a TORS, left supraglottic laryngectomy, partial laryngectomy with MRND. So it was a compartmental removal of the previous tumor site. And the biopsy revealed that there was no residual tumor. There was one metastasis, and the ENE was negative for this patient. So it was a very happy case. He did not have to receive any adjuvant radiotherapy, and he has been out for 2.5 years, and he's been swallowing well, and no recurrence of the disease. So let me just change gears to immunotherapy and checkpoint inhibitors. And some of these, the new concept therapeutic agents actually evolved in the early 2010s, and the nivolumab and ipilimumab were the one of the first to appear in the market, and the FDA approved them in recurrent and metastatic setting, especially the melanoma. And the fascinating thing about this immunotherapy and the checkpoint inhibitors is that they have a durable response. So after 24 months of therapy, their response is sustained, and the survival rates are durable over a very long time. And head and neck cancer is actually right beside melanoma have an inflammatory phenotype, which makes it a good candidate for the immunotherapy. So in head and neck, the initial trials were on the recurrent and metastatic diseases, and the results have been good. Now it's moving more to the advanced tumors and even in tumors. So in the setting of surgery, the initial idea was to do a adjuvant immunotherapy, and not only in head and neck, but in melanoma diseases. And this is one of the landmark studies that compared ipilimumab to placebo, and it showed significant improvement in the overall survival. Then nivolumab was actually compared to ipilimumab, which was found out to be more superior. And another NEJM article in 2015. And people now have been thinking, why not neoadjuvant immunotherapy rather than immunotherapy? And one of the reasons for that is um, theoretically, when you remove the tumor and then initiate the immunotherapy, your source of antibody is gone, and the immune system has nowhere to actually direct that immunity to the tumors. Whereas if you do a neoadjuvant immunotherapy, you have your tumor right there, and those all act as antigens. So once you activate the immune system, they will actually go to that antigen and prime themselves and become activated. And after you do the surgery, which is cytoreductive and removes a significant amount of the antigens, and the whatever remaining antigens or the tumors, or there might not be any more, but once you remove them, the burden for the immune system is much lower, and the immune system could act better post-surgery. So that's the idea behind the immunotherapy, and it seems that it has been proven in melanoma that the neoadjuvant is better than adjuvant. Also in recurrent glioblastoma, that neoadjuvant is faring better therapy. So in head and neck, there has been a lot of neoadjuvant immunotherapy trials going. There are a lot of them going on. None of them have reported yet, but I think we will be seeing some of the reports. And if you look closely into the trials, you can see that there's a neoadjuvant phase where you give the immune checkpoint inhibitors prior to surgery, and then after the surgery, you maintain that immunotherapy scheme in a adjuvant kind. So here's a case that I have experienced in my hospital. So he's a 62-year-old gentleman, has a right side tonsil squamous cell carcinoma, which is HPV negative, and his stage was clinical T3 and 2CM0. And we put him on a clinical trial. He wanted to enroll in a clinical trial, neoadjuvant immunotherapy followed by TORS. So he had 2 cycles of immune checkpoint inhibitor. And we did a TORS on this patient. So the initial tumor actually looked like this, and actually the tumor size did not decrease that much. So the surgery itself is very typical, lateral oropharyngectomy and bilateral MRND. So the lateral cuts are made lateral to the anterior pillars, and the superior cuts are made on the soft palate and to the medial side, lateral to the uvula. You can appreciate the preferential fat here. You're going through the constrictor muscles. You're making the posterior cuts medial to the posterior pillar. The inferior dissection is performed with a magnified view. You can see that the field is barely tinged with blood because you can actually see the bleeders very well, and you can get that bleeders with the bipolar arm. Okay, so now that the inferior cuts are made, the specimen is almost out. You have to make sure to orient the specimen, and I am actually cutting a little bit more to the inferior side to address the tongue base, and also to obtain an additional inferior margin just in case it was not enough. It turns out the tumor size was 4 centimeters. It's a YPT3, and unfortunately the patient had 9 lymph nodes, which was a PN3B, and the ENE was positive, and the patient had to have a CCRT postoperatively. It was done together with immunotherapy, and he's been on 8 cycles of immunotherapy after the CCRT, and is currently NED for 8 months. So today I've shown that the induction chemotherapy, although it's just a matter of words, but it's different from neoadjuvant chemotherapy. And the idea behind today's talk is on the neoadjuvant chemotherapy, which precedes surgery. And as you can see, that there are a lot of advantages, theoretical advantages of TORS combined with the neoadjuvant chemotherapy, but we need to wait for the trials, the results to come. And neoadjuvant immunotherapy with TORS has additional benefits. One, when you compare with the adjuvant immunotherapy, which is done after surgery, you can actually expose the immune system to initial tumor burden with a lot of antigens to activate your immune system, the T cells, and you can also expect some durable response by combining immunotherapy with robotic surgery. Again, once more for your attention.